Watching rightdoctors.com, and I am Dr. Manoria, Executive President, First World Congress of Cardiometabolic Medicine, and we have with us a renowned Dr. Prakesh Deedwania, a globally renowned cardiodiabetologist. Dr. Deedwania, for several decades we have known that anti-diabetic medications improve microvascular outcome, but they have no impact on the macrovascular outcomes. But 2014 came with the breaking news when we had the first trial, EMPERAGE outcome, when empagliflozin showed that it improved CV outcome, and this was followed by several other trials, the LEADER trial with liraglutide, the semaglutide trial with SUSTAIN 6, and then we had the CANVAS trial and the DECLARE-TIMI. So what is the current status of these new anti-diabetic medications on cardiovascular outcomes?
So I think that's a very good observation. Clearly, we had seen, as you correctly identified, control of glucose and the microvascular complication with the prior hypoglycemic drugs. Unfortunately, those drugs never had cardioprotection. Part of that could be the risk of hypoglycemia. Part of them could be the mechanism of action. They were purely insulin. Most of them were insulinotropic agents. They did not work outside the area of pancreas. Now we have exciting drugs, the new class of drugs. It started with DPP-4, incretin-based therapy. Then we have SGLT2 inhibitor, purely a new class of drug, completely new class. And then we had GLP-1 agonists, which are also incretin-based, but directly working on the mechanism. So the most exciting study came out, as you correctly identified, the EMPERAGE outcome trial that really blew everybody's mind. Clearly, nobody expected SGLT2 inhibitor to come out with such a remarkable result. And that study for the first time showed that controlling glucose alone is not enough, that you can use drugs that provide cardioprotection. And that study showed a remarkable reduction in the rate of MACE, which included myocardial infarction, non-fatal stroke, and heart failure hospitalization. And of course, in the EMPERAGE outcome trial, the predominant mechanism was reduction in hospitalization for heart failure. That subsequently was followed by two other trials of SGLT2 inhibitors. The CANVAS trial had a mixed population, whereas EMPERAGE had everybody with heart disease. CANVAS trial had about 2/3 of the patient with heart disease and 1/3 with risk factors for heart disease. And that trial showed very similar results, particularly for hospitalization for heart failure. There was similar reduction. And when you compare the two trials, the reduction in heart failure is right on the same line. And now CANVAS trial had some concerns because there was some observation of lower limb, the great toe and finger amputations. However, we have since seen real-life data and that amputation risk is not reproduced in any of the other trials, including the CREDENCE trial, which is also with canagliflozin, presented just last week in Melbourne at the International Nephrology meeting. And that trial also proved two other things. Number one, that in patients with diabetes, renal disease is quite common. We have known that for some time. And that if used correctly, these drugs, SGLT2 inhibitors, can protect the kidney. And one must keep in mind that when you have kidney involvement in diabetes, there is also similarly, at the same time, increased risk of cardiovascular disease. So CREDENCE showed not only there was a nephroprotection, but there was also a significant reduction in cardiovascular event. And in CREDENCE, there was no increase in amputation. Then we have the biggest trial, that's the DECLARE trial with dapagliflozin, another SGLT2 inhibitor, and that study is different from the other two in that it had majority of the patients that did not have pre-existing heart disease, but they were at high risk of developing heart disease. And that trial presented at AHA and subsequent two papers in New England Journal of Medicine and Lancet showed that clearly for heart failure, similar reduction in this as in the other two trials, but the MACE were not reduced as much. And this is not surprising. People are just saying that, well, how come there was no reduction in MACE? But this is largely because if you take a low-risk population for a shorter duration of follow-up, you're not going to see reduction in MACE. So in totality, when they did a meta-analysis, my good friend Mark did the meta-analysis, and they showed in the meta-analysis right on the dot, all these three drugs put together, SGLT2 inhibitors, have very similar effect regardless of their background disease, they all reduce hospitalization for heart failure. And now we are examining in the prospective trials, the Emperor trial, the DAPA-HF trial, and others that are going on. There are also several trials for nephroprotection that are going on with SGLT2 inhibitors as well, and these trials will come out very soon. So I think the message here is that SGLT2 inhibitors are wonderful drugs. Like any other drug, there are side effects. Because these drugs work by producing glycosuria, there is glucose spillage, and you must teach your patients to maintain good hygiene around their genitalia where urine is coming out, because glucose harbors bacteria, or it becomes a good media. So as long as they use proper hygienic technique, cleaning after urination, etc., the risk of genital myocardial infection can be reduced. There is also something like ketoacidosis, non-hypoglycemic ketoacidosis, but again, that has not been a major problem if you use it properly. In elderly patients, there could be some concern because elderly patients have enlarged prostate, the females have their own genital problem, and in them there could be higher risk of pyelonephritis, but again, with proper selection of patients, that can be avoided. Now, the next class of drugs which are even more exciting are the GLP-1 agonists.
You very rightly said that SGLT2 inhibitors across the board, primary prevention groups, secondary, have shown decreased hospitalization for heart failure. But in diabetes, we know we have two types of cardiovascular involvement. One is heart failure, which is more common, and another atherosclerotic disease. So if we use SGLT2 inhibitors, how we does it decrease the atherosclerotic complication, or we have to use another class of drug like GLP-1 receptor agonist to minimize the atherosclerotic
Well,
complication?
it's hard to say. They probably decrease some atherosclerotic complication, but at the present time, the indications are they work primarily on the hemodynamic aspect by reducing producing diuresis, by reducing blood volume, etc. Also, we must keep in mind that SGLT2 inhibitors block at the same time the sodium transporter, sodium hydrogen exchanger, so they produce diuresis. Now, the evidence suggests that there is a reduction in high-risk people of some of the macrovascular events, but nowhere near what one would want to see. So for that, we need to select the newer class of agents, a different class called GLP-1 agonists. And there are two trials with the GLP-1 agonists that have shown exciting results. The first one was LEADER trial with liraglutide, and the second one is semaglutide. Both of these trials showed reduction in macrovascular event. LEADER showed reduction in combined endpoint of non-fatal MI, stroke, and all that, mostly non-fatal MI. Now, the semaglutide trial, the SUSTAIN-6, showed significant reduction in stroke as well as combined endpoint. Why these drugs on different endpoints? We don't know. I mean, we are very early in the stage of this. But one thing is very clear, that the beneficial effects of GLP-1 agonist on lipids, reduction in weight, and other beneficial effects have anti-atherosclerotic effect. We need to really investigate further. There are a lot of trials going on looking at the basic mechanism. But at the present time, if your goal is to reduce both risk of heart failure, hospitalization, and macrovascular events or atherosclerotic events, perhaps one has to use a combination of GLP-1 analogs or as well as SGLT2 inhibitors. We are in the new era of diabetes medications. Certainly, we have drugs that are very exciting. At the present time, the cost is somewhat of a consideration, but one must keep in mind, if you can prevent these major events, in the end, the cost will be negated by preventing these major events. So I think we should be excited in looking at it. And as I mentioned somewhere else as we were talking, one should abandon sulfonylurea as far as I'm concerned. There is a lot of love for sulfonylurea because for past 25, 30 years we have been using it. But sulfonylureas never provide cardioprotection. And on top of that, the risk of hypoglycemia is substantial with sulfonylurea. Time has come to change that. I wrote an editorial in Journal of American College of Cardiology just a few months back explaining the dangers of hypoglycemia. In the EXAMINE trial, they looked at sequential troponin levels, and they showed that there was a minor leak of troponin in many patients multiple times that was associated with increased risk of cardiac mortality. So I think hypoglycemia is not a minor event. It occurs frequently, undetected, We only come to know of major hypoglycemia that obviously patient tells you if they had hypoglycemia, but many more episodes of hypoglycemia are occurring that are subclinical, but they cause damage to myocardium. So I think it's time to really move on and grasp and consider these cardioprotective agents. As Professor Brownwald at one of the meetings that I was chairing at American Heart Association said, that a new era has come, and there is a new specialty emerging that's called cardiodiabetology. And I think people who want to be in this business need to familiarize themselves with all the intricacies of these newer drugs and then start using them routinely in clinical practice to reduce the risk of cardiovascular events in patients with diabetes.
Thank you, Dr. Deedwania, for your flashes of expertise on improving CV outcomes with new anti-diabetic medication.